Good afternoon, everyone. I welcome you all to this session on the final day of the conference, the final session. I'm sure it's going to be a very interesting one. Let's have a more of an open discussion. If there are any questions or any comments, feel free to stop us in between. Uh, we are here talking about virtual reality simulation-based training for cataract surgery, the final frontier. We know simulation offers training in an environment where one can perform surgical tasks with multiple times without affecting outcomes. It helps in reducing trainees' learning curve, causes less complications in surgeries when they go on to live surgical training. Through this IC, we will answer some of the questions how simulation-based training helps. What is the current scenario in surgical training in India? We have a list of experts in their own fields who will talk about this. All these questions and many more will be answered in this IC. So I welcome you all to this final frontier virtual reality simulation based training for cataract surgery. The first instructor, Dr. Parikshit Gokte, will speak on the state of cataract training in India, the need for us to improve. Uh, Dr. Gokte had to leave yesterday evening, but he has made his presentation available with a voiceover. So we'll start with that presentation first. So can we load Dr. Parikshit's presentation, please? Thank you. Start from the beginning. So the state of the art cataract training in India, the need for us to improve. I'm going to speak on Dr. Parikshit's behalf. As we all know, residency training in India, we are pioneers in the Gurukul system. We have teachers who have known to become facilitators of knowledge and wisdom. There is a discrepancy in the actual number of surgeries performed by resident doctors across India, whether it's a government setup or a private setup. It changes dramatically. We know that even though the median is less than 10, and those who need to master the median is more than 50. But if you see phacoemulsification, the numbers are pretty dwindling. The residents need to be evaluated carefully and taught basic ophthalmic skills with use of equipments and in procedures in greater depth. Especially after the pandemic, I'm sure it has reduced a lot. So there increases a need for surgical training, whether it's wet lab, simulation based training, and live surgical training. This was a study done by Dr. Parikshit himself, uh, uh, which included a sample size between 2004 and 2012, and compared the residency training. The AIOS frame guidelines were used for residency training, and then we saw about the population and how much cataract is there, which is the cause of blindness, retinal diseases, glaucoma. But we know that cataract continues to be the major cause of preventable blindness in India. Uh, why we choose ophthalmology many times is we know that it's lucrative, no emergency hours, and we can devote time to families and hobbies. Uh, it's not so lucrative, we know that, in a charitable or the NGO setup. So this was also a part of what was reviewed in literature. So the mean 20th century trained, mean 21st century trained people, and we saw a p-value. This was the publication spearheaded by Dr. Gokte. Uh, it spoke about surgeries that were independently performed during residency training, right from the ICC days to ECC to SICS, FICO, and other ocular emergencies. So you can see the median is not really the median; it's varying continuously across surgical techniques. So that is really a cause of concern. So what they had proposed here was to standardize or have a structured residency training program, and need to review it periodically, have periodic governing bodies who, like the AIS or like the DNB, who can go back and see whether it's standardized across training environments in institutes. So the huge variation in all forms of surgical training, whether it's surgical and academic, needs to be addressed and is a cause of concern. We all know that it's just cataract focused residency training, but there are other forms of surgery also, right? So whether we are talking about trabeculectomy or pediatric cataract, these are not really that much hands-on. What they found out that the teachers were also not that much trained in other forms of cataract surgical, other forms of surgical training. It was more centered towards cataract. So that's where the discrepancy arose, and then the pandemic struck, and then things went haywire. Uh, everybody left their routine surgical training practices and were put on emergency duties, planned eye surgeries. Uh, Cataracts were postponed. Residents who graduated after 3 years were just some form of medical doctors with special interest in ophthalmology, no surgical training. This in turn affects the quality of surgery people perform, whether it's in the camp setup or in a private setup, which reduces the quality and increases the backlog of surgical training. So, as they say in the London Metro, mind the gap. There is a lot of gap in the skills transferred, especially with this. With this pandemic that has hit us badly, we're trying to cover it. There are too many trainees now. Trainers are more worried about good outcomes. Of course, they have multiple commitments, and the less and less exposure makes the less skilled surgeons available. How do we address that concern? And again, Dr. Gokte in his paper spoke about wet lab training as a model or video assisted teaching as a model. Simulation, yes, it plays a big role, and most of us are big proponents of simulation based training. And once you graduate, giving it back to your students in the form of reverse training and continue training them. So there are various options that are available in that. How do we address that is what we are going to talk about here. So unless we train our residents well, we are not going to have competent surgeons going forward. It's an ecosystem. Each one teach one is what we believe in. As long as one person trains at least 2 or 4 people, we are going to have a community that has a good vision, which is complication free, because of the training environment that we set up. So I thank you for your attention, and I can invite questions on Dr. Parikshit's behalf. Thank you. So before we move on to the next talk, Akshay, you have been a part of many of these publications. I'm sure with Dr. Mishra and Dr. Gokte. Um, we spoke about the north-south versus east-west India variation of surgeries that were performed. How do you see the scenario improving? Because you were closely associated with that study.
Yeah, so actually one of the questions in that questionnaire was which region do you belong to? Although we didn't eventually publish that because we felt it was kind of, may not portray certain regions in good light. The divide was very, very stark. I think the average, if I'm not wrong, the average number of surgeries that a resident in the southern region of the 4 states and union territory get is close to 55, as opposed to about 18 or 19 in the northern region, the lowest being the eastern region. So the amount of discrepancy is pretty high. I think if we do have a follow-up paper, we can write that.
So it would be interesting actually to have a follow-up on that paper. If we did implement the AIOS and the national board guidelines, how did it improve?
And also this was just post-COVID.
Yeah.
So maybe now, if numbers have picked up, because the surgeons who are then in their first years are probably now in practice, have graduated.
Yeah.
So now we would get a true sense of people who've joined in the post-COVID scenario with things probably back to normalcy. So that's a good idea. No, this was a self-reported survey. So the question was whether factors that affected reduced surgical volume in training were investigated. But I think most of them in the paper have listed that they were put on COVID duty rather than ophthalmology care. So that being the most common, and also disruption of elective surgeries.
More so because Dr. Shankar Anantan is here. He's from Arvind Madurai. Do you see these kind of fellows coming to you with joining fellowship with any kind of surgical experience, Shankar?
Post-COVID, there has been a considerable increase in number of fellows uptaking cataract and IOL fellowship. Probably only reason because like Akshay sir and Chetan told me that there is a interruption in elective surgeries being done. So all these surgeons, they didn't get their due numbers during their residency programs. So there is an increase in number of fellows being taken up in the cataract and IOL department, because post pre-COVID, if you see retina, cornea, and all those lucrative departments used to have their numbers high, and we used to have very less
Less
number of
number.
fellows. But now, because of the COVID, we have numbers coming up. So
So that's a tough ask for you again to train everybody to
yeah,
that stage of competency. Interesting. So I know we will move on to the next one, and I'm going to talk about simulation-based training for cataract surgery. I am a consultant in some form of simulation development at Help Me See. Uh, Simulation-based training, especially use of simulators, virtual reality, haptic feedback systems, has been a biggest game changer in cataract surgical training. The beauty of it is that it allows you to perform surgeries in a real life-like surgical environment. You have visuals which mimic 95% of what a real life environment will look. In addition to that, you have a system which allows you to touch and feel the tissue much like what you feel in real life surgery. The program in itself is instructor led, so there is somebody who's going to handhold you every time you go for the training. It's a week long training, and your skills level starts from the basic to the advanced. There is a performance report that is attached. The whole idea of simulation based training around an environment is to practice until you can't get things wrong, and it's not just limited to ophthalmologists. It's also to residents. It's also for seniors who want to practice and make their uh, skills perfect. It leads to confident surgeons, and that's the question that we was raised in the previous talk. Do we have that many confident surgeons right now who are better skilled, who are giving good outcomes in and reducing complications and reducing the backlog in general? So that's where this fits in perfectly. We want to have happy surgeons, happy trainers, and happy patients. So the Help Me See simulator is the only simulator available right now which has a tactile haptic feedback system. Now, why is that important? It gives you the real life like environment before you actually touch the first case when you go for residency training. So that helps in with the available advanced visual 3D visuals and the feedback. So it's a very intuitive. It responds to you. It responds to your touch. It gives feedback as you start training on it. It has a system which looks like it's a general OR system. It has haptics. You can interchange instruments depending on which stage or which technique you are in. So it's resembling a complete VR setup or an OR setup like you normally have. The haptics can be interchangeably used for in simulating whether a phaco probe or a Sinski hook or a colibri forceps, and they can be used interchangeably. Alternatively, you also have this side screen where their instructor can sit and see what the trainee is looking through the microscope, give feedback proactively, and change the scenarios if they are not doing well, come back, debrief, or move on to getting the skills done right. So right now, we have this SICS simulation based training, which is our flagship model training going on well in most of the centers globally, 51 installations already, more so at the Center of Excellence in Mumbai. Uh, we have this simulation based training course which begins with comprehensive structured training starting with the ebook. Help Me See has an ebook which is 1,000-page book. Before you start your training, you actually go through the book. Once you come to the training centers, whether you spend 4 days or 5 days, it's about knowing the skills, how to go about right from scleral groove, tunnel dissection, capsulorhexis, nucleus delivery, and cortex and IOL implantation. So all the steps are done in a very structured manner. Your skills keep rising as the day progresses. Complex steps like dissecting the tunnel, where knowing the depth of dissection is so important, which is not going to happen in real life. You either end up with a buttonhole or a premature, and that's it. In simulation, you can do almost 50, 100 times in a day and practice until you don't get it wrong. So the tunnel dimensions, how much is the length, how much is the width, how much is the inner incision size, all can be mastered before you do actually do your first case in real life scenario. So that's the beauty simulation offers you. Whether you want to do a capsulorhexis with cystitome or you want to start with a utrata, both are possible. You can do almost 100 attempts in a day. To begin with, we also can offer you something which is a fixed anterior chamber, so that there is no visco or aqueous leakage and you're good. We can also do a variable dynamic anterior chamber. There are endless possibilities on simulation. So it allows you to learn technique of any step right from the beginning to the more advanced and complex one. So this is the SICS course, which is run at Mumbai. Each day begins with prior reading on the ebook, then classroom sessions, hand holding with real life instruments, then the simulators, which is a major part of the training, which is instructor led, and followed by that are the debrief sessions, which is this is a typical training day at one of the centers of Help Me See, whether it's in Mumbai or it's in Africa or it's in China. The structure is the same, so you get the same training standardized across the centers globally. For this conference, and we are very proudly presenting another simulation-based training course, that's phacoemulsification. This involves all the steps of phacoemulsification, right from making a clear corneal incision, site paracentesis, visco, capsulorhexis, and the best, which everybody looks forward to, is the nucleotomy, the divide and conquer technique. So we reverse engineered our own foot pedal. We went through a lot of iterations till we now what is the real life like foot pedal. Whether you compare it with anything available from the industry, it is like that. It has the indentations, it has the vibrations. The capsulorhexis, the visco injection are almost similar to what you do in real life scenario. The best part is that when you touch and feel the nucleus while doing nucleotomy, it does give those vibrations. The machine makes the same sounds on occlusion. It makes the same sounds on emulsification. In addition to that, there are various guidelines. Now, in real life surgery, we really do not know. Sometimes the novice also always tends to be very superficial. We are scared to go down in the deep depth of the trench while making a trench or even dividing them. In simulation, there are guidelines which allow you to know in what depth you are. Now, the whole idea is to have a good hand-eye-foot coordination that you learn before you enter the OR, so that you replicate all the muscle memory in the OR when you start your first case. And there are evidences that suggest, and I'm sure Dr. Nair is going to talk about that, that say that simulation-based training followed by live surgical training reduces your complications to as much as 40% when you go to the live surgical training. So it does make a difference. And we have seen that happening. We have almost trained around 2,000 trainees alone last year, and this year alone we have around 800. It's just half of this year. So there is this buzz around how much simulation-based training is going to help in cataract surgical training. The steps that we spoke about are also simulated well in this scenario. We are also talking about doing complications management. So we are not just talking about basic skill set. We are talking about going one step further. As we speak, we are talking about developing vitrectomy in case of PCR. We already have certain scenarios where we are talking about how to implant an ACIOL in case of whole bag removal or something. Soon we will have iris clip lenses simulation as well. So those are in the pipeline for management of surgical aphakia. In the case of management of weak zonules, one quadrant, there is manual CTR insertion as well. So these are ancillary courses which are also offered at one of our training centers along with the main course, so that you just not learn the basics of M6 or the basics of phaco, but in addition you can club that with complications management. So it's a complete training package, so that once this trainee moves on to live surgical training, they have the complete picture. Even management of rigid pupils by doing sphincterotomy has been simulated. So we are very proud to have this setup in India with the major institutes like Arvind Eye Hospital in Madurai, LV Prasad in Hyderabad, International Society of Manual Small Incision Cataract Surgery, one of our proud partners, as well as Ajanta Pharma. So you can reach out to any of these centers or directly reach out to Mumbai to have simulation-based training enrollment and experience the beauty of the simulation-based training and the platform that offers you this virtual reality experience. It's not just India, as I said. There are almost 50 installations worldwide, ranging from Mexico, New Jersey, France, Madagascar, and China. So we are growing as a community. We are growing as a team to help residents, fellows, and ophthalmologists across the globe to learn cataract surgery, whether it's M6 complications or even phaco for that matter now, and suturing, so that in turn we do our bit to produce surgeons who are better skilled, who will go out in the community and do surgeries and help reduce the backlog of surgical training. We are in also development of other surgeries like pediatric cataract management, open globe injury, which is scleral tear or sclerocorneal tear, and a little bit of trabeculectomy. But more that I think next time when we meet in Kolkata. So far, it's about all forms of cataract surgical training. It's been a long journey. We've come this far. We are happy to have this training imparted to many of our students through us, through our partners globally, and we will continue this effort going forward. So I thank you for your attention. If there are any questions, comments, I invite them at this moment. Thank you very much. So based on this training now, which is happening mostly across the centers, of course, there is a center of excellence in Mumbai, and Dr. Chetan is in charge of that. Chetan, how has been your experience so far, especially post the COVID-19 pandemic? Do you see more interest and more enrollment? I just gave them the numbers, so I just want you to corroborate on that.
Yes, Ashish. I think it has been a phenomenal experience because we get a lot of trainees, and when they train on our simulators, and it's not working.
You just have to press it, sir.
I'm pressing it.
It's on. It's on.
Okay, yeah. So as I said, it has been a phenomenal experience. We have been getting a lot of trainees after the COVID incidents, and when they come to our center in Mumbai and they get trained for the 4 or 5 days on their surgical steps, and when they go back and do live surgeries, they reach out to us and give their feedback. So they see marked improvement in their surgical skills, and they also recommend our courses to a lot of people. And this is word of publicity by mouth, like, and then we get more trainees, and we have been escalating, and yeah, so yeah, we have been growing. Yes.
Thank you, Chetan. So when we talk about imparting it through us or through partners, what can be a more bigger mecca of ophthalmic surgical training other than Arvind Eye Hospital in India, in Madurai? So may I now please invite Dr. Shankar Arandan R. Ravila to speak about his initial experience with simulation-based training in a tertiary eye care center at Madurai. Dr. Shankar, over to you.
Thanks, Dr. Akshay, for this opportunity, and help me see also for this opportunity and recognizing Aravind as one of the centers in your. So I have no financial interest to declare, and so just to set the context, I'm just sharing the details of the performance of Aravind Madurai alone in terms of surgical volume. So why is this number important? This 1.9 lakhs that we have done last year. Why is it important? Is you can see now most of these surgeries, or at least 70% or close to 65% at least, have been done by junior medical officers and doctors who have very minimal exposure. So this is the main reason why we tend to take training very serious. So account the total number is 78,000 that were performed by juniors, and our seniors had conducted a study in which they have found out that it requires at least a number of 300, close to 300 SICA surgeries to have their junior surgeons bring their complication below 2%. So 300 SICA surgeries, it's quite a lot of number. So we need some kind of a training module which can bring it less than 300. So that was the main goal. And so the other thing is, like in an SICS in general, we should understand that how much ever you train a surgeon in whatever subspecialties they do, cataract surgery unfortunately is still the bread and butter for most of the surgeons outside. So you need to master this well to make even your basic income, if because outside that is the scenario. So in SICS, if you can just learn the basic steps to perfection, it will reduce almost most of your intraoperative complications in whatever challenging situation that the surgeons may handle. And this will always reduce the learning curve also, and the residents will love to do surgeries. Though that is the main reason why we need to train them better initially. And so these are the what, even though simulator is new and new to the scenario in training, we can't forget the we can't forget the history which has brought us to this stage. Like AIOC sir have all been trained in cadaver eyes and rexus boxes. So what did the traditional wet lab training lack, and what has simulator brought up as an advantages? Like if you consider a person training in a gym, a person training in a gym can always go and work out and come. But when you have a personal trainer standing nearby, he'll be the person to dictate to tell you exactly how to do it, what muscle, what exercise needs to be done. So a simulator gives you that advantage. In cadaver eye or in rexis practice in a polyethylene film, we will never know in what angle the trainee practices in what depth he is in. But when it comes to the uh, when it when it comes to the simulator, that's the biggest advantage. And so the disadvantage in the old methods were, especially during the pandemic period, we didn't have the chance to give any of our surgeons, junior surgeons who are still in the institution with us, a chance to perform live surgery. Had we had the simulator at that time, at least they would have practiced it m number of time. So putting it into context, now we got the simulator with the help of our management in 2021 and 26th March, and that's me here practicing with our getting introduced to the simulator in the Mumbai center, and still far we have trained 168 surgeons. So now we categorize our surgeon trainees into 4 categories. So the first one being the fresh graduates who have literally no experience with MSICS. So this group trains with us for 1 month. So every month there are a set of residents and fellows who get trained in SICS with the help of the simulator. And the second, third, and fourth are groups which have approached us literally seeing the benefit of the simulator helping the junior surgeons. There have been surgeons who wanted to quit surgeries, but now seeing how the residents are doing well, they approached us on their own. And actually this group was not there before. Even Ashish would agree, is an old alumni of our institution. So they created this group. Like they came to us and they requested, sir, I am having too many complications. So that's the group. The second, they have done lot number of surgeries, but still their complication rate is high. So we brought them, we worked up with them for 45 days, we constantly monitored them. And then the third is much more interesting. Like we have fellows who are doing 30, 40 per ton, but they want to do higher volumes. So they feel, because like I told you, another important thing like I told you was, like post COVID, we have increase in number of fellows, but you don't see an increase in number of patients on a single day. So what do we give them? So we can give them only 2 tons, maximum 3 tons a week. So we need to accommodate all the surgeons also in the 6-day period. So every turn they would like to do a high volume. So for that they need to be trained well, they need to be confident, and they have to also have their complications less. So this was always achievable by the simulator, because they can practice empty number of times. A tunnel they can do 100 times, the rexes they can do 100 times. So whatever it is they can do, how many, and in particular is high volume, they may have some lacuna in particular step, that alone they can practice. Because and another thing that I failed to mention was, in the cadaver eye you can't do anything other than the rexis and the tunnel, but when it comes to the simulator you can do A to Z entirety. And the last is with the complication management system that they have brought up, the group 4 surgeons, now they are high volume but they want to do manage complications. So it helps us reach to this stage like much earlier. For example, we have few of my fellows who are sitting in the audience also. They were initially to come to this stage pre-COVID. The fellows, they used to take around 2,000, 1,500 cases. But now we have fellows who have done only 900 cases, close to 1,000, but they're able to manage others' complication and their own complications. So this gives a big advantage for the simulator. So this is an if you see, these are medical officers who are trained, PGs who are trained with us. They have the numbers, but see, their complication is quite high, resurgeries are quite high. And once they trained in the simulator for a month, this is the jump. And this in between, she went on a leave long term, so she hasn't come back yet. But look at this number, 2,290. Previously it was 726. So this is big jump from 239 to 876. It's a very big jump. So these numbers are not only, these are not going to be seen by your colleagues on a day-to-day basis, but they see your confidence. They see your face after your surgery, that brings them the confidence, and they come to us, they approach us on their own, and they train with us. So as Ashish told us, the suturing module, phacoemulsification and trabeculotomy are down the pipeline. It's going to come, and this is going to increase our workload a lot. They may just give the machine, but it is going to pressurize more. So advantages, like I said, you don't need a cadaver eye. You can practice how much ever time you want. And the most important thing is, like in the previous first presentation, it was mentioned that the trainers have a lot of other things also to be carried on as their role. So you don't need someone to stand next to you. The machine literally spoon feeds you. It's like holding your hands and doing stuff. And next is the remote training. Like we were very fortunate to have one of our one resident to be trained by remote training from Mumbai. He's doing extremely well now. So it doesn't mean like you need to have anyone standing next to you. You don't have to be in the same room, in the same floor. You can be anywhere and you can still monitor what your trainee does. And the ebook, like Dr. Ashish said, it's an A to Z. The first time when I saw this book, there were lots of questions as a trainee, as a trainer, and as a senior consultant. This book answers all those doubts from A to Z. Rather than teaching, it also answers the questions also. So it's a very good. It's an online ebook, so you can always have access to it. So when you give a job to your colleague or anyone, there must be something for them also in it. You can't just give it to them, because it won't be a continuous cycle. So as a trainer, they become more aware, they become confident, their complications come down, and they're more consistent also. So when they teach, they hear what they say, and they become more and more confident. It makes the trainer want to learn more about a new cataract surgical procedure, challenge himself, so that he can be able to train much more people. So like I said, training is not something that's going to stop today or tomorrow, or it's a continuous process, both for the trainer and as well as the trainee. So with this, I feel, and in Aravind Madurai we are offering a 1-week course and a 10-day course, which involves only the simulator. And in case you need to use the live surgery part, then you need to enroll for a 1-month period. Okay. Thank you.
Thank you, Dr. Shankar. That was great, actually, to gain more insights about how the training has affected with the introduction of simulation-based training at Arvind. We could see the numbers of those particular trainees go up, and I'm sure when there is one instructor less looking at these trainees, the volumes also go up for the other surgeries in Arvind. So that was very nicely presented. Thank you, Shankar. The next speaker is Dr. Chetan. We are going to talk about newer paradigms in surgical training. Can we do it remotely? If there is a simulator on the other end and the instructor is on the other side of the world, can that really happen? So I hand it over to Dr. Chetan to speak about remote training on a surgical simulator, how we achieve this feat.
Thank you, Ashish. Good afternoon, all.
Chetan, there is one question. Yeah. I'm sorry, can you say that again? It is available for the registered candidates, but it is available for the registered candidates over a prolonged period of time. So even if you're registered today, we give it for say 6 months or something. So it's an encyclopedia, the M6 ebook, because it's a 1,000-page ebook. Nobody has heard about having a 1,000-page ebook full of media in the forms of animations, videos. I would encourage you to have a look. I have a demo. I'll show you that. Probably that will help you. Yeah. It's for all steps of cataract surgery, right from making the incisions till hydrating the wounds. It's not shown in some of the videos for paucity of time. It takes you through the entire steps of surgical training. So whether you do a rhexis, nucleus dislocation for M6, or a nucleotomy, emulsification, implantation of foldable lens for phaco, even suturing. We have a suturing concept where you can do suturing multiple times in a day. So it is for everything. PCR, yes, we are working on anterior vitrectomy now, so I wouldn't divulge much details, but it is going to be available soon to manage your own complication, like doing anterior vitrectomy, making the cortex wash, implanting a multi-piece lens in the sulcus, in the end suturing the wound. So that's coming soon. Yes. Thanks. Okay. We move on to Chetan for remote training using a simulator. Over to you, Chetan.
Thank you, Ashish. Good afternoon, all. We ended with a good note from Shankar that learning is not a destination but a continuous process. And we all know how important training is, and we all know how COVID impacted this very important aspect of residency training, which is surgical skills. And there were hardly any opportunities for the residents. We imagine whether we can bridge this gap and somehow impart surgical skills to these trainees who were in their residency and who suffered badly because of the lockdown, where they were completely taken away from their ORs and they could not have any hands-on experience on live surgical patients. So can simulation-based training bridge that gap? And we realized that we needed to do something there to bridge this gap and provide training to these residents who were actually sitting in their hostel rooms without any clinical experience. And uh, there is wherein we thought of remote simulation based training, because as you know, in COVID there was travel bans, and we could not meet each other. There were no classrooms, there were no one-on-one interactions. And as they say, invention is necessity is the mother of invention, and therefore we had to think out of the box and invent something which will still help the trainees while they were under lockdown. And there is where remote simulation based training originated. So what actually remote simulation based training means is that the instructor and the trainees are at remote locations. Something like this had never happened before, because surgical skill transfer, as you know, is a very personal thing. You have to be present in person in the OR to train. But with the invent of simulation and with the addition of remote simulation based training, we were able to achieve this during the lockdown due to COVID. So, talking about Help Me Seize Eye surgical simulation based training courses, they are little different from the conventional courses in the sense that they are more structured, and there is always an instructor present to train the trainees. So we offer different courses. So we have a 4-day course on M6 surgery. We have a 1-day course on complications management course. We have suturing course, which is again a 1-day course. And very recently launched, in fact, it is launched here in AIOC for the first time in India. We have the PSTC, which is a phacoemulsification simulation-based training course, which will range anywhere between 4 to 6 days. So we have partnered with very key institutes in India. We are in partnership with LV Prasad, where we have 2 simulators, and we offer all our courses at LV Prasad. We have our very close partners in Arvind Eye Hospitals in Madurai, and we have Dr. Shankar representing Arvind here, and they are one of our key partners, and they have been training a lot of residents on the simulators. We have some of the beneficiaries of simulation-based training sitting in the audience here, and I would like to know from there what their experience was. But these institutes have been helping us with simulation-based training, and we have taken that pain to train specific individuals at these institutes so that they are in position to train others on the simulator, because simulation based training requires trainers. So we have to train the trainers first. They have to understand the machine well, they have to be competent on the simulator. Only then they can impart a training to other residents. Apart from our main center in Mumbai, where we have 8 simulators, we have 2 simulators in Hyderabad at LV Prasad and 2 simulators at Arvind in Madurai. So the instructor training program, as I said, it's a very specific program, and we take the instructors we are training the trainers there, and we take them through different phases of training. We make them go through the course as a trainee. We let them observe some trainings, and at the end of it, we ask them to present or train dummy trainees, and this is how they come to know about the different features of the simulators. There are certain nuances of simulation-based training that one must master before they can be qualified as instructors. So we qualify instructors depending upon the courses. So with the addition of every new course, we have our director of simulation-based simulation development here, Dr. ASHISH BACCHAV, and he spoke about the courses that we keep on adding constantly. So for every additional new course, we have to train the instructors separately, because they need to understand the assignments well, and they should be confident in doing those steps on the simulator before they can actually train residents on those courses. So we all know how badly COVID impacted residency surgical skill transfer. There were less opportunities to train, there was social distancing being done, and there were travel bans. So nothing happened, and I really feel bad for these batch of trainees who could not have a lot of live surgical experience. But there is where simulation based training can fill in the gap. So can we really train surgically using simulation, and that too remotely? That is a question that we asked ourselves, and we tried to experiment there, and we invented remote training. So what exactly does it mean? It means that when the trainer and the trainees are at different location, and this training is delivered using internet-based services like Zoom or Microsoft Teams. The level of separation could be different. There was a time when we were at the same center, but the trainer and the instructors were sitting in different rooms because we had to maintain social distancing. It could be in different cities, it could be across continents, and we have very well trained people from Mumbai. We have trained people in France, we have trained people in the US, we have trained people in Madagascar, in Mexico. So this is where a remote simulation based training played a very key role, and we could not have done it without remote training. So how is it different from other forms of remote training? So this is not merely a webinar presentation that we are talking about, because there's actual surgical skill transfer happening there. It involves skill transfers and therefore requires constant monitoring and timely corrections, needs good technological and equipment support, and requires careful observation of the grasp of instruments and the technique that the trainee is performing on the simulator. Equipment support is very key for remote surgical training. We need good internet connectivity, we need good viewing screens, we need good audio visual units, because you need to constantly communicate with the trainees, and we need laptops and things like that. There are specific gadgets that we had to invent to perform this remote training, and it was hand position cameras and headset and microphones. I'll show you a picture. So this is the microscope of the Help Me See eye surgery simulator, and we can see that two features were added to perform remote training, because initially we did not have any microphone in the microscope, and we did not have any camera in the microscope. But then a need was felt to observe the trainees' hand positions and the way they are holding the instrument. And a need was also felt to communicate with them and correct their grasp of the instruments and their movements on the simulator. So we invented these two gadgets in the microscope, and it made our life very easy. We could communicate, we could observe what the trainees are doing, and this is a typical view that an instructor gets to see remotely on his or her laptop. And we can see this on the left is the camera view of the grasp of the instruments and the hand pieces that we have on the simulator, and on the right what we have is the performance of the trainee. So a trainee is being performing a paracentesis here on the left side, and very clear instructions can be given to the trainees, which can help them improve their skills. So we train people in China, we train people in Madagascar, India, US, France, and it consisted of both instructor training as well as resident training. So this is a typical scenario. This is a training room at BACCHAV Medical College, and we can see there is a large screen and a classroom was being presented from Mumbai to BACCHAV Medical College. There are 4 residents who are sitting next to their simulators, and after the classrooms they would begin their simulator practice, and the instructor would continue to observe their performance on the simulators using the microphone and the cameras that we have in the microscope. So this is a typical setup, and we could fuse both the views from the 2 simulators on single screen, and therefore one instructor could monitor anywhere between 2 to 4 trainees and 2 to 4 simulator views. So this can be done in a multi-centric way. We have sometimes residents. Dr. Kima is our lead instructor at Mumbai, and she sometimes monitor trainings at multiple centers. She monitors training sometimes at Japromed and Mumbai continued, and that is how remote training increases the productivity. So one instructor can be present at 2 locations and provide training to 2 big locations with to the big group of anywhere between 6 to 8 trainees. That's a huge achievement that we were able to do due to remote surgical training. It obviously has its own challenges. We need good technical support. The cost is high because there's a requirement of good gadgets in the form of screens and microphones and cameras. There could be language barrier, especially when you're training across continents. There could be internet issues, and there could be difference in the accent of people, and there could be difference of time zones, and the connect, although it is very good, it is still limited because we are not physically present, and we cannot have the kind of interaction that one would have in presence. So the results of remote surgical based training was that it can be achieved remotely. The skill imparted are equivalent to in-person training, which was a huge discovery. And even after COVID ended, we have continued to deliver remote training because we feel that it is equally effective, and it is equally beneficial, and it is a good use of our resources. Good technological support is of paramount importance for remote training, and we need to have good set of gadgets to conduct this training. The summary is that remote training is a remarkable example of how obstacles can be overcome and surgical training achieved remotely with the help of simulators and simulation-based training. And I would like to end with the note that there was no parallel example of surgical skill transfer done remotely across the globe. So this was one of its kind training done using the gadgets that we have currently, and it was as equally effective as in-person training. Thank you all for your patient listening. Thank you.
Thank you, Dr. Chetan, for taking us through something which is very difficult to achieve, especially remote training on surgical simulators, and that experience will help us going forward to train multiple people at multiple location with the same instructor. So that's a paradigm shift again. I would say a game changer in remote surgical training for cataract surgery. Dr. Shankar, you have a question?
Thank you.
So, are you proposing any studies to see the efficacy of this remote training with any of your
Definitely,
partners?
that's a good idea, and in fact, we have a large pool of residents
So
now.
this is a way of me also getting you to answer a study with us.
Yes, you are always welcome. You are very esteemed partners of ours, and definitely would like to have these kind of
So
studies conducted.
we will work it out then.
Definitely, Shankar. Thank you.
Thank you, Chetan. Thank you, Shankar. Yes, sir.
I mean, all we need there is a simulator, and we can train remotely. So yes,
All I can
mean,
say is, Chetan,
yeah,
that we are talking to somebody in Bangalore.
exactly.
Maybe it will take some time. Yeah.
Sir, but
Definitely.
in the meantime, we have a workshop in Madurai also for 1.5 days workshop. If you want to refer any of your residents, you can always refer. 1.5 days, it will give you entire experience of the entire. We had an workshop last in January this year. Around 30 people attended from hands-on on the simulator for 45 minutes, and it will give you the entire spectrum and feel of it, and then you can come down for a 1 week program also. The workshop is for free. The registration is very less. It doesn't cost much. I'll get you the details and we will share it with you, sir.
Thank you, Chetan. Thank you, Shankar. When we talk about surgical training on simulator, we also talk about assessment, and I briefly touched upon it. So may I now invite Dr. Kimaya to speak about machine learning and AI, how simulators assess surgical performance. So over to you, Dr. Kimaya.
Yeah. Good afternoon, everyone. I'm going to talk about a very interesting topic, machine learning and artificial intelligence, how simulator assesses surgical performance. So as Dr. Ashish said, Help Me See simulator is the only simulator which has haptic feedback based, and it has an intuitive simulation software. Our simulator assesses the performance of a trainee by using CMOSCR criteria, which is actually assessed by 12 international experts from 8 countries. This is how the CMOSCR table looks like. Here you can see all the steps of M6 surgery and how you have to grade a student, like if it's novice or if it is a good student or if it is confident surgeon. So in Help Me See simulation training, we first give first few attempts as in learning mode, where the training tools will be visible on the desktop screen of the student. Complications, if he does something, it's visible on the desktop screen. Performance data is seen when you click on the desktop, and you can see how you are performing in the particular step. And we aim to get maximum satisfactory attempts from every trainee. And if the trainee has satisfactory attempt, then only we shift him to the assessment module. So here, because the trainee is doing good, there are no complications shown on the desktop. So now here the trainee is completing the capture axis. We go inside like this, and trainee is doing good tear. He's starting the CCC and he's completing the CCC as well properly. But if at all the trainee has something like this, and if the tear run out, then the machine will definitely give you a sign of tear out, and the instruments will turn red. This simulator assesses itself. So now instruments are turned red, and this is a game over situation where the trainee has to perform a reattempt. He cannot continue the same attempt anymore. So there are some of more complications like endothelial touch or contact with iris. The simulator gets itself with a software, and it will tell you that you are doing some complications. Be careful. So In cortical wash also, you can see such complications like capsule aspiration. And as this time we have launched FECO, so even we have these criteria for FECO as well. So here the surgeon is touching the anterior capsule. So you can see that the mark, which is a green color mark, is showing that the phaco is too much near the capsule and is touching the anterior capsule. Here it is near the endothelium and you are causing damage to the corneal endothelium. Here the trainee has made a very deep trench, so the simulator assesses everything and gives you the feedback. Here there is a total, because the instruments are turned red, that shows that the trainee cannot continue the surgery again because he has done too many complications in the same patients in the simulator, of course. Then like this, you can see on the desktop screen where you have, on the right side, you can see all the complications which are there. So here the trainee is actually caused a posterior capsular rupture. So if you click a button on the desktop of performance data, you can see all these components where you can exactly see what all, in which steps you have gone wrong and what you have done. Basically, if you have done how much zonal breakage, how many times you have done endothelial touch, everything is assessed by simulator. It's unbelievable actually. So here, because it's 10% of zonal breakage, you can still continue that. But if you are actually having capsular rupture, then you cannot continue. The simulator assesses that as well. So here, when the trainee was doing the 4 quadrants, this you can see on the scores. And because he has done already rupture, the simulator gives you minus scores. So even that simulator can judge that much of in depth. So coming to assessments, when we get satisfactory attempts from a student, then only we shift him to assessment, as I told you before. And this is the different mode where we can shift the student and he does assessments. The main thing is in assessment, the trainee will not see any complications, even if he does anything. It is not shown on desktop. This data actually we are using and in something called as ATMS, Advanced Training Management System, where this data we use and to grade every student differently. So this is how we have to go in the system and we have to start grading the student. Here you can get all the steps. We go in each and every step and grade every student. So suppose this is for scleral groove. So one student is not doing properly. So I have given the rollover. Rollover means if the student is not doing well, you want the student to practice something more. The next day he will come and practice the same step again. So as an instructor, I will give a rollover to him. So this is already recorded here. And the other student is doing well, so I have given proficient certificate to him. So this data is analyzed by something called as SBLS, that is simulation-based learning system. So this report, as instructors, we get it daily in all our centers, may it be in India, outside India, everywhere. Here we get exactly what all the student has done, what all different steps. Of course, we always see how many satisfactory attempts every student has got, how many times the students have got game over. So we can actually see the performance of the student from this data. And you can see even this is whenever you see the data directly visually also you can say that which student is doing which step better. When you get too much of oranges, that means the student is actually making complications. If you are getting red zone there, that means students are getting game overs many times. So this is where we know that the student has to improve more and we have to give him more attempts to do. As against, whenever we get such a report, that means the student is actually very well performing, he's getting all satisfactory attempts whatever he's doing. So as a instructor, we are happy and trainee also is very happy with us. So it's very important for us as a software with this, and we are, as Dr. Shankar said, as an instructor, we can basically give a very effective feedback to our trainees. So thank you so much for patient listening.
Thank you, Dr. Kimaya, for the wonderful overview of how you assess the performance on the surgical simulator. It's also important to hear from the end user who have undergone simulation based training. We have amongst us a very distinguished person, Dr. Vignita, who is in the audience, and she has undergone simulation based training with Dr. Shankar at Madurai. I don't want to put you on the spot, Dr. Vignita, but I would be very happy if you share with the audience your experience on virtual reality simulation based training on the Help Me See platform. Thank you, Dr. Vignita. Yeah, no problem.
Good morning, been there for simulation training program for 1.5 days. It's actually very nice to have the feel of the uh, instruments there. Being the wet lab there, as you said, wet lab is just going to give us the tunnel feeling and the rexus feeling. And the other steps are not going to be as good as the simulator one. Simulator is taking us the way, reading us, get us repeat the steps equally, and it's nice to have a progression in it as we have a repeated thing going on. As muscle memory is going to happen very
Yeah.
soon. It's nice. Thank you.
Thank you. Thank you for sharing, Dr. Vignita. We appreciate your comments. Thank you. Sir, you had a question.
Yeah, but in this scenario, the trainee had actually, it has gone towards posterior capsule. But definitely. But the thing is, we have not simulated can opener technique in simulator. That is the main thing. Otherwise, I would have taught in live surgery the same way. Yeah, yeah. So machine has not developed can opener technique because now we are promoting only CCCs as a standardized technique. So we are, yeah. And because so whenever I am standing with a trainee and if I notice that the tear runout is going to happen, immediately I tell the trainee to pull the capsular towards center directly, not towards the iris background. So that because we are standing with the trainee, it's actually this thing will not happen as routine. This is extreme case which we have shown to demonstrate. Yeah. But yeah, yeah, definitely. Yeah, so I definitely will say that. Yeah.
So those things are covered on the classrooms and one-on-one basis. The idea is to talk about a standard capsulotomy technique, which is a capsular axis. But we do speak about envelope, can opener. We even talk about femtosecond capsular axis for that matter. So it is a complete training environment. What you see is the simulation, which has to follow a standardized pattern, which is followed globally. So that's why the capsular axis. But you're absolutely right. We speak about all these things and join them together so that the trainee is not clueless. What should I do next? But in simulation, there are some things where we need the simulation to stop and move ahead with caution. So that's what she was talking about.
In fact, we discuss about different types of capsulotomies and actually preference of capsulotomies as well. So even that is been covered in the classroom sessions or even debrief sessions. So we take care that the trainee will go with full knowledge if he's with me. Yeah, I know. Yeah.
Actually, it is on the good side, sir, because we train so many people. When you give them that idea of rescue maneuver, you don't get to be called at all. So they do it on their own, and at the end of the day, we will never know what they have done. They will say their exercise is complete, and we go with the PCR, and you find a flap lying over there. So it is always better to train your trainee to do it perfectly from the beginning, so that the question of rescuing maneuver comes only when challenging cases, not in routine cases, because an IMC can also go to a PCR. So in a way, perfection is what the simulator aims for, and it's really good because trust me, sir, it took me 180 attempts to do a perfect rexus in the simulator. Even with our experience, we didn't get it that easily. So yeah.
And also, it's on a simulator that you can actually tell a trainee, okay, try a run out and try to bring it that in. You'd never have a live instructor tell you operating on a patient, try doing a run out and then try to bring it in. So that's the advantage of the simulated environment.
Basically, I would like to share because I have experienced both the things. I was a live surgery trainer also. So here my BP is very low and nice. So that was very different from the live.
Talking about training the trainers, I think we have Lipok here, who is our qualified instructor at Arvind. So Lipok, would you like to share your experience of going through this journey of getting trained as a trainee and then becoming a trainer eventually?
Lipok is our fellow. He joined us, and certain things that we are very proud about is like we have people like Lipok, 4 or 5 of them with them who are just 1.5 years into a fellowship, and they're now crossing their 1100th mark of surgery. And to tell about Lipok, he has only 2 complications in his entire 1200 cases. So he's and I say that is not a good thing. Like Sir said, I wouldn't say that is a good thing because he's not able to manage others complications. So now we are going to push him up to do that. So he is a high volume surgeon as well. So yes, Lipok.
You can send him to us for complications management course.
Sure, sir. Sure, sir.
Yeah, this month I'm a trainer, SIS trainer, as well as a simulator trainer. So what I experienced is just last week, one of my trainee, she's a fellow. So she was repeatedly making a mistake in the training, that is in the patient side. But I couldn't tell her why she's making a mistake. So I went to wet lab, I mean the simulator. I showed what mistake she's making. If you do this, you'll be making this mistake. So after I showed her, she's not repeating the same mistake. So sometimes we can't show what mistakes they're making in the patient's eye, because patient's eye we can't take a risk of making mistakes there. So we can take the we can take the opportunity of this simulator to show what mistakes they are making, why they are making. We can make the mistakes there and show them that this is the reason you are making this mistake, and you can correct it. And later on, she was comfortable doing that. That was a keratome injury. It's a simple step, but she was repeatedly making the mistakes. It was causing TM detachment and all. Did not much, but so it's costing patients vision. So it was quite helpful. Just last week experience.
Your trainer, your experience as trainee.
As a trainee. So it was. See, I came to Aravind with very minimal SICS exposure. So after I came, I didn't know how to handle even the instruments properly also. So it started with those basic steps only. And forget about the surgery. I didn't know how to handle the instruments. All those basic steps are very important. I repeatedly tell the PGs, fresh PGs, and especially and fellows. Even now, fellows are coming with less experience like me. So I tell them how to handle the instruments. So even these small steps are very important. In OT, you can't tell all these things because many patients who are waiting. We can't take much time on all these things. We can tell the simulator how to handle all those instruments, and if they are making mistakes. See, I was making lots of mistakes in tunnel also. So my instructor, she taught me how to do those in the correct way, like tunnel making, So I improved it, and maybe that's why it's my complication also it has reduced. I'm not sure, but maybe.
You're very humble, Lipok. Yeah. But thank you for sharing your experience as a trainer and a trainee. Thank you very much.
Thank you, Lipok.
More when we discuss about our experience, the panelist experience, the trainee experience, we also want to know if there is evidence which is objective, which is substantiated by data, which is published in peer-reviewed journals. We have Dr. Akshay Nair today, who will take us through the evidence part of it. Akshay Nair is involved in simulation-based training, publications. Let's hand it over to Akshay, the expert on publications. Akshay, over to you.
Thank you. I think we've heard enough of how simulation can help train people, but I think the proof of the pudding is in the eating. So we've trained people in simulation, they've operated, but has it really helped in improving outcomes, in improving patient safety? And that is what we'll be looking at. These are my financial disclosures. So before I jump into the evidence, I just want to give an overview that while we've been focusing on virtual reality-based simulation training and especially the Help Me See Eye Surgery simulator, simulation is not just limited only to virtual reality-based simulator. There are a lot of different types of simulators, like clinical skill simulators that can help you train in direct ophthalmoscopy, indirect ophthalmoscopy, laser procedures, like the RETI or the Simuli, where you have small little fundi that are 3D printed and enclosed in an eyeball on which you can practice how to focus and take laser beams. Similarly, you've got animal models, human cadaver models, you've got virtual reality based models, inanimate object. So we largely hear about wet lab, dry lab, and the concept of how these two are distinguished. So we call them wet labs because they're basically using chemicals and tissues that can be wet hazards. Like in this photo, you see a goat's eye that has been, in which the nucleus has been removed, and a delivered nucleus from a human eye is then put in, and then phacoemulsification is being done in it. So this is where biological tissues like human eyes, animal eyes, especially rabbit, pig, and goat's eyes are used, or we can even use vegetables, fruits, or a combination of all of these. You also have wet lab training where inanimate or artificial eyes are being used, like this kit or the Kitaro eye kit, where you've made a paracentesis, created an anterior chamber, filled it with viscoelastic, and on a cellophane tape, you're doing a capsular excess on there. So you can learn how to do the task and the hand movements required in capsular excess. But as you can imagine, each attempt that is done utilizes one eyeball, and therefore the kind of expense that goes up with these kind of training devices is quite high. As is with this, the Vetret Philip eye used for vitrectomy, or a stretched out taut aluminium foil used for capsular excess. So how do we know it works? Dr. Kimea Chavan briefly described about how surgery is, how training is performance on the simulator is assessed. There can either be a cognitive skill assessment or a technical skill assessment. And we spoke about the ICO Oscar. Now, ICO Oscar is basically, Oscar stands for Ophthalmology Surgical Competency Assessment Rubric. This is there for phaco and SICS. Now, similarly, there is also a SIM Oscar, where you are able to assess the performance on a simulator. And this has also been validated by Wildean's group, where they trained trainees in Africa on a simulator and compared their performance on the simulator and tried to correlate it with real life surgical performance. There are different other virtual reality based simulators that have inbuilt scoring system and assessment, and we saw a bit of this. Now I'm going back to the Help Me See Eye Surgery simulator, where you can see that here the trainee is trying to deliver a nucleus, and while delivering the nucleus, a complication is happening. So it gives you the alerts that there is zonular damage, and while it gives you the alert that that is happening, the trainee knows, the instructor knows, and of course, as was mentioned in the previous talk by Dr. Kimea, how the simulation-based learning system captures all this information and gives you a scoring and tells you whether your attempt was a satisfactory one or not. So the advantage of virtual reality-based simulators, as we've been harping on and repeating ourselves, is there's no worry of collateral damage. There is no worry that if I have a run out, if I have a posterior capsular rupture, what will happen to my patient? Because here the advantage of being able to learn, relearn, unlearn, and do multiple attempts without stress or fear remains there. Additionally, the visuals, the graphic, the depth, and the haptic feedback add to the realistic learning value. Now we've figured out how simulators assess things, how performance is graded on the simulator, but does that mean anything? Well, we go back 10 years ago in 2013, this was the first paper that actually published how simulation-based practice improves performance of capsular excess by trainees in an operating room. It improves intraoperative cataract complication rate, and therefore based on papers like this in the UK, now there is a mandatory 60-hour requirement of all ophthalmic trainees to undergo simulation based training before graduating into live surgery. Similarly, papers from Scandinavia have also been published, and we've also presented our construct validity study recently at ARVO. Again, capsulotension ring also has been studied, and this was our crown jewel, the publication that we had a couple of years ago, a randomized control trial where we had trainees who came in from 3 institutes, partner institutes, who came into Mumbai, learned on the simulator, went back to the parent institute, and their first 20 surgeries were recorded. Similarly, the control group who learned surgeries at their own parent institute and then started doing live surgery, again, their first 20 surgeries were also recorded, and the first 20 cases of each of the 2 groups of trainees was masked and reviewed by blinded observers and then they graded these surgeries based on technique, outcome, and errors. And the analysis showed that the number of errors by the control group, or the group that did not learn on simulation, as you can see in the orange colored bars, were significantly high. It was high for all errors, significantly high for major errors, and for minor errors. So if at the end of the day you're able to reduce errors and complication by a trainee simply by putting him on a simulator rather than making him operate on a real eye, imagine the amount of benefit that patients can perceive from this. So simulators allow you to have different assessment tools in a stress-free environment with minimal collateral damage. Even though it may have some amount of expense associated with it, there are long-term benefits because it allows you to have customizable scenarios, and it has changed the landscape of training. And at the end of the day, while we are improving technique, we are improving skills and confidence. The most important thing that we are improving with simulation-based training here, along with the Help Me See Eye Surgery Simulator, is patient outcomes, because that's the only thing that matters in the end. Thank you so much.
Thank you, Akshay, for getting us through the evidence, and I'm sure we are all excited to also have a similar study done for phacoemulsification. So let's build up on that when we get back. But thank you for the wonderful talk, all the speakers. It was great. I invite sir to have questions. You're the only interactive audience we have. So do you have any more questions, comments? Please use the mic. Feel free to use the mic.
No, I think it's difficult to say that it's the end, but yeah, no, I think it's not always, in places like India and Africa, it's not always easy to dismiss non-simulated traditional training because of resources that are limitedly available. So I don't think it's the end, but there's a clear advantage in simulation. That's all I can say.
So at the moment, sir, there is a role for everything. It's where you place it in surgical training right now. Once we go through that path, and we know that this definitely is going to be the future, we'll gather more evidence. There will be more partners like Arvind, and probably then you can say that it is now coming to an end. But right now, the way it is placed, I think it only adds to what you already have. It only adds to the current surgical training in reducing complications, as Akshay said, in improving patient outcomes. That's what everybody wants, right? So the entire effort that Help Me See's a virtual reality simulation based training platform puts is getting confident surgeons and reducing complications, thereby increasing patient outcomes. That will also come down. The more it's like the catch and mouse situation. The more people get involved, everything comes down. So yeah.
Sir, sorry to interrupt, sir, but sir, nowadays they're getting more stipend than what I'm getting, sir. So they can easily be, for their career, they can pay, sir. But having said that, sir, everything comes with a price, because for you to tell you the real truth, till date, Help Me See is doing it for non-profit. They are not charging anything. We are charging it on our side to help them become little sustainable. So it's not like they're aiming for the money part, but only when you pay something and come inside, you will learn it seriously, sir. Because if you take an institution, if you sponsor it, you're eventually going to ask that surgeon to come back and show his performance. So if everything is going to be for free, there isn't going to be any seriousness in the time they spend with us. So,
and sincerely, we are teaching them from 9 to 5, so that goes without saying, right?
Right. Any more questions? We are good. I think we are well within the time. Thank you, everyone, for. Yeah. Yeah. So it is attached. This is the bigger version. We are also working on a light version. I would not divulge more details on that, but this there is a portability component that we will work on for sure. Yes. Yes. Right. Thank you.
Thank you all.
You didn't see it? I'll show you.